name is Sarah King. I am a naturally curious person, especially when it comes to our bodies, and even more especially when it comes to women's bodies, because if you don't already know, women's bodies really have only been studied in the past 40, 50 years. That's it. So I have a lot of questions. In this episode, we're talking about Polycystic Ovarian Syndrome, or PCOS. It is super common. You will be surprised about how many symptoms can be associated with this syndrome. So let's just jump right in. Today, I have Dr. Darlene Esper. She is an OBGYN with WakeMed, and we're going to talk about PCOS, also known as Polycystic Ovarian Syndrome. Thanks for coming in today.
Thank you for having me.
So we're just going to start from the beginning. What is PCOS? We're going to say it that way because it's a long name.
Right. So PCOS is Polycystic Ovarian Syndrome. It affects usually about 5 to 15% of women of reproductive health.
Wow.
Sometimes patients don't really even know that they have PCOS, and it can be diagnosed as early as adolescence. What makes it a little bit confusing, usually, to have the diagnosis, there are two key characteristics that you need to have. One is evidence of anovulation or oligoovulation, which means that you're not ovulating every month during your menstrual cycle, or maybe you're not ovulating at all. And then the other one is evidence of hyperandrogenism. And so that can be anything as simple as like having acne, hair that's noticeable in other places besides your head, like facial hair. Sometimes women can have male pattern baldness or other signs of androgen excess, oily skin. They may even notice skin color changes where there's darkening underneath their armpits, breasts, or their neck, and that shows you that there's a little bit of insulin resistance.
And what exactly is happening? These are all the symptoms. But
Right.
What exactly is this syndrome?
Well, the syndrome is with PCOS, essentially what happens is it's a metabolic disease that can be multifactorial. So because of the insulin resistance, your body has higher levels of glucose. And
why is insulin resistance a part of this? I thought it was about your ovaries. Does your ovaries infect your insulin?
Well, your ovaries can affect your insulin in a sense that when you are, for most women that are PCOS, about 80% of them are obese. And with obesity, our fat cells convert to a type of estrogen. So there's an estrogen excess over progesterone. And so then your ovaries are not producing normally. They're not firing off the hormones as normally as they should.
Oh, interesting.
Essentially, your brain sends a signal to your ovary every month so that you can have a period. And with the PCOS ovaries, sometimes they're not getting that signal. So occasionally you have a period, sometimes you don't. And with that imbalance of the hormones comes menstrual irregularities and then the long stream effects of PCOS.
When your brain is saying, it's time to have your period, where is the signal going? Like, does that question make sense?
Yeah. So your brain always sends signals to the ovary, and with the PCOS ovaries, those fall because with PCOS, polycystic means you have multiple follicles on the ovaries. Now, you can have polycystic ovaries and not have PCOS.
Okay, so
if that makes sense.
What is a polycystic ovary?
So normally all ovaries will have a few follicles that develop. And in order to, let's say...
What is a follicle?
A follicle is essentially like an egg that's in the ovary.
Okay.
And so you release an egg every month, right?
I see.
And so then if that egg fertilizes, you get pregnant.
Right.
And if you don't, it just gets released. Sometimes you can develop a cyst, that
Gotcha.
sort of thing. With the polycystic ones, you may have over 10 to 12, and they don't respond to the stimulus from your brain as normally as a normal ovary.
Oh, wow.
But you can have polycystic ovaries if you don't have the other characteristics like the hyperandrogenism, then you don't necessarily have PCOS. So you can't have just the ovaries. Essentially, the classic diagnosis years ago, even when I was in training, is you had the polycystic ovaries, so you would get an ultrasound to make sure they were there, and then the evidence of the hyperandrogenism, and then on top of that, the oligoovulation or irregular menses. But now you just have to have two of the three. And
I see.
And essentially then you rule out other causes, right? Because there can be other causes of having excess facial hair, like anything that can raise your testosterone level, a testosterone producing tumor perhaps, or there are certain metabolic disorders like Cushing's that can cause that. And so we try, anytime we're suspicious of the diagnosis, then we at least rule out certain metabolic abnormalities.
Oh, that
first.
makes sense.
Yeah.
So is it painful? Because it sounds like if you have multiple cysts going on, it would be painful.
No, there's usually not pain associated with it because the follicles are inactive. Now, if many PCOS women are infertile, and when they undergo perhaps like IVF or any type of ovarian stimulation, when you have a number of follicles, those follicles will get really, really large. And so then the ovary gets kind of swollen, and that can be painful during the ovulation induction process. But prior to that, it's usually not painful.
And this is in like 15% of women.
Up to 15%.
Yeah, that's a lot of people.
And we're seeing more of it because, essentially, the disease process, a lot of factors kind of overlap. And because we have a rise in obesity, those women that are obese are going to already have androgen excess. But it's
because the estrogen mimics estrogen.
The fat cells will cause your estrogen levels to be higher. And then you can end up having those metabolic derangements that are associated with PCOS. There are also hereditary components that kind of lead someone to be obese or at risk for PCOS. So it's not uncommon for a patient, when they come in and we do a family history, to see that, up to 40% of the time, a mother or a sibling also had that diagnosis.
Yeah. What exactly is androgen?
Androgen excess is anything that causes, androgens are hormones essentially. So like testosterone would be a type of androgen. And so your adrenal glands produce androgens and the ovaries produce androgens as well. So you need them to function essentially, but you don't want them to be at a higher level than what's normal.
I didn't realize being obese makes that happen.
It does. It can increase the amount of like estrogen, circulating estrogen, and then you want your hormones to, everyone, especially now in this day and age, is talking about hormonal imbalance, but there are a number of things that you can do to balance your hormone. And the easiest thing that we recommend when we know that someone's suspicious of having PCOS, the first thing we recommend is diet and lifestyle changes.
Like what?
Just weight loss would be number one. So oftentimes when I see these patients, it's because they're trying to get pregnant, for instance. And so the first thing I tell them, because typically their BMI usually is over 30. Now, there is a subset of women that are really thin, about 10% of the time, that also have PCOS, but more commonly it's associated with obesity. And so the first thing I tell them is, even if they just lose 5 to 10 pounds, or 10 to 15% of their body weight, they may notice that their cycles become normal. And I've seen it happen where I prescribe weight loss, and patients come in and they now have normal menstrual cycles.
Wow.
So that's the easiest fix.
But it's easy. But losing weight is so difficult.
Right. Correct. I mean, that would be the kind of least risky way to do it, because the long stream effects. We have to be frank with patients when they come in. Most of the time they're focused on, my period's not regular, or maybe they want to get pregnant.
Sure.
Right? But once we make that diagnosis, we also discuss the long stream effects, like the cardiovascular abnormalities that can occur.
And this is a complicated syndrome.
Yes, it is. Yes, it is.
I mean, it's like you just keep piling things on.
Right.
Okay, I'm sorry, I interrupted you.
No.
So you were saying that there are, what kind of cardiovascular stuff
So they can be
happens?
at risk for heart attack, stroke, diabetes more commonly. So and any of the effects that the long stream effects associated with obesity.
Oh, wow.
Yeah.
Well, why do the dark patches happen?
That's called acanthosis nigrans, and we see that even in non-PCOS patients that have had diabetes for a long period of time. They get like velvety skin changes from the insulin resistance. So that's due to higher glucose levels in your body.
Interesting. It's so funny what the body does.
And so really you can, when a patient comes in, and I can almost know right away just looking at them. And then if they say, well, I'm not having regular cycles, and then I look and I see that there's chin hair, or in an older woman, we don't usually see this in adolescence, you'll see male pattern baldness that's associated with it. Or, because for teenagers, if you see acne, you're not jumping to PCOS.
No, of course not.
Because it's a common complaint for teens.
What about, I hear skin tags also?
Sometimes skin tags can be associated with insulin resistance.
Tell everybody what a skin tag is.
A skin tag, if someone's probably seen one before. I know I used to have a sister who had one on her armpit, and I constantly would like cut it off or what have you.
You'd cut it off for her?
Yeah,
Sisters.
or sometimes people would put like dental floss or something and just kind of
And they come back?
Yeah, they do come back. Sometimes they develop in areas where there's trauma. So like areas that you shave, armpit, folks will notice them around their neck if they wear a lot of necklaces. Like I see that you have a lovely necklace on,
for
Sarah.
years.
But sometimes that like irritates the area. There can be genetic, predisposition to skin tags as well. It's not always associated with just PCOS, but we do see it in patients that have difficulty with like insulin resistance and elevated triglycerides as well.
Oh, interesting. So like I know a young person with PCOS. She's really young. She's not obese, but she definitely has it. And she has a lot of problems with her diet. Like she's got gluten intolerance. She's got dairy intolerance. Is that normal to go with this kind of thing?
Well, I will say that when you have a little bit of, because there is an inflammatory condition that occurs with that.
Of course it does. Why not just add that on there?
Everything is inflamed. So definitely in patients that we don't usually see folks that have celiac or what have you and also have PCOS. I think it's two separate entities, but there is an inflammatory component that's associated with PCOS. And we know with numerous studies that higher glucose levels in the body or a difficulty metabolizing that glucose because of the insulin resistance can lead to inflammation throughout the body. So it may make someone more susceptible to gluten, because gluten is inflammatory. Dairy is also inflammatory. Most experts that speak on an anti-inflammatory diet, right? The first things you remove are gluten, dairy, and sugar, and all of those are inflammation. If you want to, have an anti-inflammatory diet.
So sad. Like the best part of the diet.
Oh, I agree. I love gluten, and I do love dairy at times, but I think if most people even took themselves off of it for a short period of time, they might notice that they're feeling better, because sometimes those spikes in the glucose, if you're not regulating it properly, can make you feel lethargic, you crash, that sort of thing. So I think it's all about balance.
Yeah.
Right?
Yeah. It's just hard in our society with all the processed foods.
Exactly.
And it's just in everything. And even if we try to avoid it, it's just like, it's like another job.
Right. Exactly. So you almost have to eat everything that's not in a package.
Exactly.
Essentially.
Which like Whole Foods. Yeah.
Yes, exactly.
So long term, there's a low grade inflammation. Why is that?
Again, the inflammation is related to the glucose intolerance. So the inability, because insulin regulates your glucose levels. So if you have insulin resistance, that you're going to have circulating glucose that is unable to break down. And that is the downstream effect of that is inflammation.
Our diet is so important. So do you often send people with PCOS to dietitians and nutritionists?
Yeah, I offer that, especially if they are obese. I personally really love being healthy. If you talk to my family, my son is always asking me, is there gluten in this? Because I like gluten and that sort of thing. So he jokes about that. But I'm a health nut, so I try to spend as much time with my patients talking about nutrition, and sometimes I just recommend an anti-inflammatory diet. We do have nutritionists at WakeMed, and so I offer that service as well.
Yeah.
But for some patients too, it's time and cost, and I think there's so much valuable information out there now on the internet, and there's a lot of resources. So sometimes I'll prescribe a book for them, give them a challenge for a few weeks and see how they feel, if they notice any changes.
Well, there is a lot of information on the internet, but a lot of it is garbage.
Sure.
So what are some sites that people can go to, or books?
Yeah, so for our women, I would say you can always refer to the ACOG, the American College of OBGYN website, so acog.org, so acog.org. They have patient pamphlet information that even if you typed in PCOS, it will answer questions related to that and
that's
keep
cool.
it at a layman's term and doesn't go into too much of the scientific part of it, but explains it really thoroughly. And then they also have resources on those websites as well. There's a PCOS Foundation, and you can get information from that site as well. And any of the, sometimes offices, medical offices will have blogs where they've tried to kind of educate the community
that way
on certain things. So I think that's the most reputable thing. I would probably recommend that most people avoid TikTok and Instagram as just their sole means of information, but certainly you can find great recipes and things like that.
Once you know what's fact versus fiction, then you can start discerning on for yourself.
Right. Because I think if with improvement of lifestyle and dietary modifications, patients will notice that their menses returns. Suddenly they're fertile again. They may have higher energy levels.
Does the hair go away?
It starts to improve. Most of the time when we're kind of addressing concerns, usually the PCOS patient has a specific thing that they're targeting, right?
Yeah.
Like for someone who's not interested in getting pregnant, maybe they're coming in because of just the hair, right?
Yeah.
And if that's the only, and I've seen patients that's all they complain about.
Sure.
So the first thing I do is rule out PCOS, right? And then I also need to make sure that there's, again, not a testosterone secreting tumor or anything like that, because I have seen that. We've also seen really healthy women. I had a patient years ago who came in with just severe acne and development of new hair. And I honestly thought she maybe had a testosterone secreting tumor. And what it ended up being is she was taking some supplement at the gym and she didn't know she was taking steroids. It was some steroid component.
Oh my gosh, she was taking
didn't really know. She was taking roids and she didn't even realize it.
Was she angry all the time?
She noticed that she had a deeper voice, but not yet. And sometimes what can happen when you're taking steroids or you have a lot of excess estrogen and androgens is like clitoral enlargement, those types of things. So, and she had no idea. She thought she was just taking something. I remember her telling her, I thought she was taking something similar to creatine just to help with muscle. But we had to send it off to a special lab because it wasn't like the strict steroids that you see.
I hope she sued that company.
No, well, it was a friend at the gym, so I don't think she sued anyone. But anyway, so you have to rule out all of those things first.
There's a lot there's just so many components to
and
this.
it's not just one. It's just not one facet.
So. Well, and I've also read that there are 4 types of PCOS.
Yes.
So I've heard there's insulin resistant PCOS,
which is the most common.
Then you've got post-pill
PCOS. Sometimes there's some new research out there that patients, because pills are androgens, right? It's estrogen and progesterone.
Yes.
And so sometimes patients are susceptible to those hormones that they're giving themselves, essentially. So they might notice some changes related to that. More commonly, sometimes we'll have patients that notice that perhaps they started developing acne after the pill. Oftentimes we use the pill to treat acne.
Okay.
But that may be one component of it. Regardless of all the different subtypes, we treat them all the same.
I see.
So, but this is different kind of avenues that it can get diagnosed, essentially.
Let me just finish this list out. Yeah, we got adrenal PCOS.
Right. So if there's an adrenal tumor, so that will increase the amount of hormones that are in your body, androgens.
I'm learning androgens.
You are androgens. so you can have the PCOS syndrome just based on that because of the excess androgens.
And then you have the inflammatory PCOS, which I thought was a symptom, but no,
just from inflammation in the body,
and it can cause it.
Yeah.
That's amazing.
It can cause your hormones to go up. And, now we're seeing, most people are reading about balancing your hormones, and all the inflammation, like balancing your cortisol level and the downstream effects of that.
And cortisol is related to stress.
Yes.
Yeah, which is like, in this world we're living in today, getting rid of stress, it seems impossible.
Right. But there are ways to kind of modify your stress levels, right? I think
exercise is good.
Exercise is good. Really good sleep habits. I think as Americans, we have really poor sleep habits. And I touch on this.
Not Gen Z.
No.
Gen Z is into sleep.
Right. They are into sleep. But in general, even like the fact that we use our phones so frequently, that when you wake up and reach for your phone in the morning instead of being outside, it can mess with your circadian rhythm. So you're not getting really good sleep. And alternatively, if you are going to bed with your computer or watching TV, the blue light can be really damaging. So you really want to aim for 7 to 8 hours of sleep. You want your bedroom to be kind of an oasis.
Sure.
And you want to essentially have an hour and a half where there's no technology prior to optimize your sleep. I mean, that's what most sleep specialists will say.
And you do that?
I try to do that, yes, because even sometimes my husband will catch me because he used to always be on his computer. I'm like, turn the computer off. Like, it's affecting my,
You're like, you're giving me blue light.
It just depends on how my week's going because sometimes I'm returning emails, but I really,
So you're not a doom scroller.
No.
Good for you.
No. But oftentimes I notice that if I am returning emails or if I stay up to watch a movie with my kids, like I'm wrecked the next day. So
wow.
I am like, as my husband says, I'm like a blue hair. So I try to eat early because also if you are eating late and then you go to bed, usually some specialists will recommend 2 to 3 hours to allow your body to digest before you go to bed to improve your sleep hygiene. And I don't think that we all do that. I mean, it's very regimented.
It's very
right?
hard. Well, I am a morning show radio host. I do
Yes.
mornings. So I get up at 4, right? And so there's no sun.
No,
and I do
true.
go outside, so my circadian rhythms are bad.
Right.
I go to bed with my kid who's watching TV, and it's like the only time I get to see him, like at night, is right before so there's that, and then dinner is like maybe an hour and a half before bed. So I am just basically screwed.
I honestly, I think we all deal with that. I mean, my family makes fun of me because sometimes I'll make dinner. My kids play sports, and so we're not eating till late. But most of the time, I sit with them. I've already eaten like at 5:30, and I just sit with them because I know that if I eat late, I don't sleep well.
Okay.
And as an OBGYN, most of us are sleep deprived, and so
that makes sense because babies come at night,
right? And so you can't go through multiple days of like sleep deprivation.
Believe
we know what sleep
me,
deprivation does.
Believe me, I know. All right, let's talk treatments real quick.
Yes.
All right. So, is there a cure for PCOS?
Not necessarily. I wouldn't say like a cure. Definitely you can reverse the effects that are there, right? Because especially if there's a genetic predisposition. So certainly your androgens will go down if you lose weight, for sure.
Okay.
100%. Definitely, depending on what the patient is complaining of, like the first line therapy, let's say it's just she wants to regulate her menstrual cycles, which is a really common visit.
Not knowing when your period comes sounds like a nightmare.
So the first thing we do is put patients on combined birth control pills. Now you might say, well, what about post pill?
Sure, yeah.
But most combined pills are progesterone dominant, and when we're talking about especially the obese PCOS patient, the estrogen level is higher than the progesterone. So if you give the birth control pills, you can help regulate their cycles. The downstream effect is decreasing their androgens. Sometimes it can help control some of the excess acne and hair growth.
So when you say combined birth control pills, that means that there are 2 different hormones within the pill.
There's estrogen and progesterone.
As opposed to one or the other.
Right,
Gotcha. Okay. Birth control helps, but what happens when you want to have a baby?
That's a great question. When you want to have a baby, the main thing is if we're not having menstrual cycles, right? So how do we get patients to menstruate? Sometimes we have to induce a bleed for them to know when they're menstruating. And what we do is we give them just progesterone for a few days. Every time your progesterone levels go down, so when you stop taking progesterone, you usually will have a bleed.
Okay.
And then we recommend timed intercourse so that they know when they have their period. If that doesn't work, then sometimes we use ovulation induction medications. Like you've probably heard of Clomid, or right now the first line therapy is letrozole. And so we may use those agents. If that doesn't work, then we may go to injectables. But even prior to that, on that first visit, if someone really wants to get pregnant, the first thing I say is lose weight.
Yeah.
And then come and see me back, in a few months. But at least, again, I mean, I know it seems like a really difficult thing to do, but 5 to 10 pounds
is not a ton.
It's not a ton, depending, it's still challenging. But not only that, when we're looking at the risks that are involved with obesity and pregnancy, they're very high. There's a higher risk of diabetes in pregnancy. There's a higher risk of hypertension in pregnancy, preeclampsia, dysfunctional labors, increased risk of cesarean section, increased risk of a large baby.
All because you're carrying more weight.
Yes, all because you're carrying more weight.
That's so fascinating.
And so really, if we can optimize our health before we get pregnant, then not only, again, will they feel better, they'll have a better chance of a pregnancy outcome. So,
diabetes medication, can that help? A1C?
Sometimes it can. Yeah, absolutely. We used to routinely, back when I was in training, a lot of the PCOS patients were automatically placed on metformin, which is an oral diabetes medication that's been around for a really long time. And in fact, 20 years ago, we were using metformin and an ovulation induction medication, Clomid, at the time because we thought that was better to do a combination. Metformin, one of the positive side effects of it, if you are obese, not only will it decrease your insulin levels, but a lot of patients lose weight on metformin.
So is it semaglutide or is it something different?
It's something different.
Okay.
So and certainly now that the semaglutides are here, but again, the main thing is you're getting weight loss.
Yeah.
And so it's the downstream effect of weight loss, but it can also help with your sugars
right.
as well.
Okay. Do you ever get to the point where you have to have surgery with PCOS?
So there is a procedure called ovarian drilling or laparoscopic drilling.
Oh, dear God. That sounds horrible.
It's not terrible. I mean, give
it a better name than drilling.
I will say it's not very common now because there's, IVF and artificial reproductive techniques that are out there. But essentially, I did it a few times in training, and that was like 20 years ago, and I haven't done it since just because there's so many medications and avenues that are less kind
invasive,
of aggressive, right? Because you have to be put under general anesthesia. Laparoscopic surgery you recover well from, but still that is the riskiest intervention that we can do besides, if we go with diet and lifestyle changes and then medications. So it's not commonly performed anymore.
So I'm hoping the answer is yes to this because it's very often not, and then 5 other bad things are tacked onto it. Does this end with menopause?
Most likely, but
finally,
where I would say no is that, again, when we're worried about excess estrogen, one of the side effects of excess estrogen, so estrogen helps build the lining of your endometrium so that you can prime for, that's what sheds when you have a menstrual cycle, but also helps prime your uterus for a pregnancy if you're trying to get pregnant, right? Mm-hmm. If you have that imbalance and you have all this excess estrogen, right? And so that's why the PCOS patient essentially maybe has a period 1 month and then 4 months later has a really heavy period because finally that progesterone is like kicking in and they've had that withdrawal bleed. But over time with excess estrogen, you can develop endometrial hyperplasia, which is an abnormal growth of the lining of your uterus, and that can put you at risk for endometrial or uterine cancer.
Oh, dear God.
So if you've been PCOS all your life and now you're menopause, sometimes those patients end up going into menopause at a later age because they still have estrogen.
Yeah.
Right? So the patient that goes into menopause early is really thin, maybe a smoker because smoking decreases your estrogen. And the women that we see that are still cycling, in their mid-50s, it's because they're heavier. And so they still have circulating estrogen, which, the positive is you're not having hot flashes, that sort of thing. But the downstream effect, especially if you have unopposed estrogen, you don't have enough progesterone in your body, is the possible risk of endometrial growth and endometrial hyperplasia.
Yikes.
Yeah. So it doesn't necessarily go away.
Okay.
But we can help mitigate it and combat it, essentially.
Well, now we're going to go to listener questions. Okay. I don't know what these are, so these are my favorite because some of these are candid, as I like to say. This person says, I have PCOS and I recently started IVF.
Great.
Will my history with PCOS affect the outcome of the IVF treatments?
Sometimes with PCOS, like your success rates may go down again because of the amount of circulating hormone that's there, kind of what we spoke about before. So I think every REI out there, reproductive endocrinologist, will still recommend what I'm recommending first. Lose weight. And really, before I even refer anyone, I really try to prescribe that and help them get through that. But they're still they'll still recommend that. Essentially.
Well, there are some things I'm on the fence about with obesity and having to lose weight for, but it sounds like this has been very well proven.
It has been very well proven. And again, also, what I try to emphasize to patients is the weight loss will not only help you get pregnant, but it's going to help you have a really successful pregnancy.
Yeah.
So that's really important, especially if you're investing all of this time and money with IVF. Yeah,
because IVF is very expensive. Okay, next question. If long-term inflammation is part of PCOS, would an anti-inflammatory diet help out even hormones? And should that be the first line of defense? I can answer this. Yes.
Yes.
Because I learned that today.
There are a number of, probably one of the more popular ones is the Whole30 diet, right, which is an anti-inflammatory diet. But for our listeners, I think the easiest thing is if you had mentioned it before, Sarah, if you can eat whole foods. Yeah. Like it's not about being low carb or anything. If you can balance your plate with carbs, fiber, fat, and protein, and a lot of protein. And maybe if you are more on the diabetic side, lower glycemic fruits, lower glycemic.
Like berries and things.
Berries are wonderful. But even when we think about starches, like a sweet potato over a white potato, or low sugar veggies like,
carrots.
Carrots have sugar. Zucchini,
Yeah.
broccoli, any of the cruciferous vegetables are really good for you.
Okay.
So you can still have those things. But also, if you're eating those things with protein and fiber, your glucose spike's not going to be as high as you just getting up and just eating waffles in the morning and nothing else. So
and then the inflammatory starts.
Right, exactly. And then the inflammation just sets, and that's a downstream effect from that.
Okay. Is it common to have thyroid issues along with PCOS, like Hashimoto's?
Yeah, yes, it can be. More commonly, we see patients who have PCOS who have hypothyroidism.
So quickly, just very briefly, what is Hashimoto's versus hypothyroidism?
Hashimoto's thyroiditis is a more common form of hyperthyroidism, or so when you have like an overactive thyroid. So sometimes once they've had treatment, their thyroid is a little underactive at that time. And with an underactive thyroid, you may have weight gain, which then
starts the whole cycle.
Because again, it's almost like a Venn diagram where little pieces then start to affect each pathway.
Yeah, that makes sense. Okay. I've read about a supplement called, and I can't pronounce it, inositol.
Inositol.
That's it.
And sometimes you may see myo-inositol. So it's a carbohydrate, and there have been just a couple of studies out there. It's pretty safe to take. What it does is it decreases your circulating. It helps decrease your circulating glucose levels, essentially.
Okay.
So it's not harmful. We don't have a lot of information of its use in pregnancy. It's really difficult to do medication studies on pregnant women.
Yeah.
But certainly that's something that folks can try. Again, I'm of the I try to avoid medication if I can, if we can do something else. So again, if I can emphasize, lifestyle changes before that route. But there is some information about inositol and its benefits, and it hasn't been shown to be harmful.
Okay.
So
well, that's good. And then last question, what kind of doctor should I see with PCOS? OBGYN, obviously, but should I also see an endocrinologist? Is there a hybrid practitioner that could be a better choice?
I would say if I had to pick, I would, see an OBGYN. Some OBGYNs, like I serve as a PCP for some of my patients, depending on...
What's a PCP?
Primary care physician.
Got it.
Sorry. So, and it depends on really how many medical comorbidities they have. Like, do they have so many medical issues that they need a endocrinologist, right? So if you had, pretty severe high thyroid disease, for instance, then I might see an endocrinologist as well. But your primary care physician is going to be important when you have PCOS because of the downstream effects, like the cardiovascular risk, the risk of diabetes, the risk of hypertension, all the lipid abnormalities that can occur from PCOS when it's untreated, especially because again, it's related to obesity.
Gotcha.
So I would see the OBGYN first, because sometimes the first thing you're complaining about is menstrual irregularity or the inability to get pregnant. But your primary care physician will also be able to manage some of those things. And then if they feel like you need a specialist, you could see an endocrinologist. But you don't always need to start with an endocrinologist, because sometimes if you correct the metabolic disorder, then all of your, other hormones are become regulated again. So you may not ever need them.
Yeah, that makes sense.
Yeah.
That was a tremendous amount of information. The fact that I can't get over is how excess sugar can convert to estrogen? What? To share your thoughts on this episode or to send me questions for a future episode, go to WRAL.FM/Sarah Has Questions. The link, as always, is in the show notes. Sarah Has Questions is a production of Capital Broadcasting Company. My guest today was Dr. Darlene Esper, an OBGYN with WakeMed. To find out more about her or any of the other providers from WakeMed, go to wakemed.org. Thanks for listening.